Hi, my name is Dr. Igor Tabrizian. I'm a qualified medical doctor with a background in integrative and preventative health. On this channel, I'll explore evidence informed approaches to optimize well being from nutrition, gut health to hormones, energy, and everything in between. Please note, this information I share is general in nature and not intended to be used as medical advice. Always consult your own healthcare professional before making any changes to your health routine. Welcome to my next podcast, which is called Serotonin Part 1. Now, this is probably the most misunderstood of the neurotransmitters that we've studied so far. And I want to put it into a different perspective from what you might have heard. So the first thing is that the name serotonin came sort of in the middle of the research related to this particular amine. It was initially called enteramine, and they found it along the lines of the intestine, and it was secreted to help with the peristalsis and the secretions of the bowel. And this is why serotonin has been very helpful in the treatment of constipation and the understanding of abdominal pain with no other explanation. But it was also called 5-hydroxytryptamine, which is a more technical name for it, the actual chemical name for it. And then serotonin came along, and that was because it had an effect that mimicked adrenaline somewhat, that could raise the blood pressure and was released during stress, not just in the intestine, but in the bloodstream in general. So some of the things you might not be aware of in terms of its job description is that serotonin actually has an anti-inflammatory role in the periphery, and it's involved in immune responses and inflammation. It's quite an important anti-inflammatory. Another thing you might not be aware of is that it's involved in the liver in terms of repair of the liver, especially after surgery or trauma. But the best known situation application of serotonin is probably in this situation. So the hard sell is you have a chemical imbalance and you need more chemicals to fix it. So that's been the hard sell for quite some time now, because 30 years later, the Royal Australian College of General Practitioners are telling the GPs and the public that this is probably not true, that depression is not caused by a chemical imbalance. That was a very large study that was published about 10 years ago. The Guardian started to say probably what most doctors were not willing to say to their patients. If low serotonin levels were really what made you feel depressed, then increasing the levels of serotonin should alleviate symptoms right away. But antidepressants don't work immediately, and in fact can take more than a month to alleviate symptoms. The third point is new estimates now show that current antidepressants on the market only work in about 60% of patients. If low serotonin levels were really responsible for depression, then increasing serotonin should have worked on more than 60%. Now, there's a slight flaw in there, and that is SSRIs, or serotonin reuptake inhibitors, can only work if you can make serotonin in the first place. And this is probably the reason why they don't work in children very well, and in 30-40% of adults. So the assumption is from that drug that you can already make serotonin. We're just going to give you a bit of a supercharging. The third point the Guardian makes is then evidence, if low serotonin levels are responsible for depressed mood, then we should be able to induce depression in people by decreasing serotonin. And we should find low levels of serotonin in patients with depression. But neither of those things exist. And in fact, there's some evidence to show that some patients have high levels of serotonin and are depressed. And it wasn't until we had functional MRIs that we knew this. So does that mean that everyone should just tear up their scripts and give up? No. If the thing is working for you, then it's working in a mechanism that may not be explained just yet. And I want to give you a really good example of other situations where this has happened. I was an anaesthetist for 8 years, and I gave over 10,500 anesthetics, a lot of them with volatile agents like halothane and enflurane. And these are gases that you get as you're going off to sleep and to keep you asleep. Now, at that time when we were giving these, and this goes way, way back to since the days of chloroform, we know that other anesthetics, the gaseous anesthetics that followed halothane, enflurane, isoflurane, these gases could create general anesthesia, but the mechanism wasn't entirely sussed out. So in fact, we're using these drugs for decades without actually knowing how they work. So the fact that we did, because we built up a database of safety and usage that we could follow and get the benefits of it without necessarily having the biochemical and pharmacological explanations of their actions. And it may well be that the SSRI drugs fall into this category as well. They either work or they don't. And in general, the safety profiles of these have been adequate enough to be used for decades as well. So, next step is the previous theories about how these drugs work, or how serotonin actually functions, is that there's a single synapse where nerve A talks to nerve B, and there's an autocratic system here where all of the information is decided by one nerve, a bit like an emperor. But in fact, the true description of this is there is a balance between these neurotransmitters of other types like dopamine, histamine, adrenaline, noradrenaline, serotonin, and in fact, our whole persona works more like a a mixer for audio purposes. We've also realized that it's not just one neurotransmitter that can leap across these synapses. So the autocratic model of one synapse has one neurotransmitter also not quite correct. So this is called co-release, where there's two neurotransmitters being released at the same time. And some examples are acetylcholine and ATP, the energy molecule, GABA, acetylcholine, glutamate, and GABA, noradrenaline, and ATP. So if you think about the release of two neurotransmitters at the same time, let's say glutamate and ATP, what is that doing, and what is the benefit of this? So for instance, in this situation, glutamate's being released and going across the synapse to the other side and setting off a chain reaction, but ATP is also being released at the same time. Now, it doesn't go to the other side, but it gets monitored by the astrocytes, or the glial cells that make up 50% of the brain. So what's going on here? And isn't ATP an energy molecule? What's it doing sending signals? Well, you'd be surprised to know that our old friend, the phosphate group, turn up in ATP because it's basically adenosine with 3 phosphates. And these phosphate groups can bind metals. This is the same mechanism of why chemicals like glyphosate can bind iron, for instance, in the gut and cause chronic iron deficiency. It's because the oxygen groups will bind to anything that has a 2+ charge. So with the two types of ATP, the top one is a linear molecule, a straight one, and the bottom ATP is a bent one. So if you're trying to determine which of these is the energy version and which of these is the neurotransmitter, it's probably demarcated as to one of those two. And so years ago, this is from a very old biochemistry textbook that I have that's in the garage somewhere, and I remember looking at this diagram thinking, I wonder where this turns up in biochemistry. And then 20 years later in Scientific American, the explanation turned up here and the whole process of co-release. But wait, there's more. There's also co-transmission. So co-transmission is where two neurotransmitters are released at the same time, but they're not in the same package. Whereas co-release, they're in the same package. So again, we have some more combinations here: dopamine and glutamate, GABA and glycine, acetylcholine and vasoactive intestinal polypeptide, acetylcholine and ATP, noradrenaline, ATP, and glutamate and calcitonin gene-related peptide. So there's quite a few of these as well. So why do we have these parallel systems? It's to do with the monitoring of where these things are occurring. So the glial cells basically are the second recipient of these. They're the ones that create the myelin that increases the speed of conduction. And so to send them a separate message is sort of like a blind copy of an email. And the second messenger is probably to do with this. Now, what are the glial cells doing? The glial cells are basically eavesdropping on neural networks. They're keeping an eye on the bigger picture of things rather than the minutiae of life. And so what's the purpose of this? Well, the glial cells basically are important for making new neural networks. But in order to make new neural networks, sometimes you have to cull old neural networks, and this is very important in the first few years of brain development in children. So their function is to both build pathways and to cull old ones. And of course, hacking a track through the jungle means you're making a new pathway. So that's basically their architects or maybe renovators of the immune system. But the truth is that we do not have an autocratic system for nerve conduction. It's more like this, where you have the major nerve releasing its neurotransmitter or co-release neurotransmitters. And on the side, you have a series of nerves that are either promoting this release or inhibiting this release. So they will send messages. No, don't send that message. Wait a minute, just think about it. And the other one will be saying, oh yeah, send it. We need to send it. So we have this voting system because in fact, each nerve, especially in the brain, has about 1,500 synapses. And there are 30 trillion nerves. So you can imagine the complexity of something like that is very difficult to depict on a diagram. But the balance of the voting determines whether the primary nerve sends its message or not. So we have a counting system, then we add them up, and then whoever wins, the synapse will either fire or it won't. But it certainly isn't as simple as this. There's probably nowhere in the central nervous system that has just one single synapse. It's more closer to this and probably this because it's in 3 dimensions. All right, so what about how do we make serotonin? Well, I said to you that one of the reasons you find low response rates in patients with the SSRI drugs is that they can't make serotonin in the first place. So how actually do you make serotonin? So how do you make serotonin? You start with proteins, you digest them, you extract the tryptophan. The tryptophan goes up to the brain. The tryptophan is activated by tryptophan hydroxylase to get to 5-hydroxytryptophan. This enzyme needs vitamin D to help activate it in the brain, and the 5-hydroxytryptophan is converted further to 5-hydroxytryptamine or serotonin. Now, the very first part of this implies that we can find proteins that have significant amount of tryptophan. Now, here's the bad news. In terms of these neurotransmitter precursors, amino acids with the lowest abundance in human foods are cysteine, which eventually gets converted to glutathione, and then tryptophan. So it's the second least plentiful amino acid in a human diet. So if it's responsible for happiness and optimism, there's going to be a bit of a shortfall there, a supply chain problem. Now, this information, probably wondering where it came from. It actually came from an obscure journal called Nature, who's been publishing since 1869, I think. It'll be November 4, coming up to happy birthday, Nature. So, yes, amino acid variability, that's where this information comes from. So, tryptophan is the second least available amino acid to humans. So, the symptoms of tryptophan deficiency would be, first one would be lack of optimism, the feeling of lack of hope. And you could say that serotonin is the chemical of hope. And then that makes a lot of sense when it comes to the stress response. So if serotonin is released something like adrenaline during stress responses, for serious stress responses, like a tiger chasing you, what is it doing in the brain? It's keeping you optimistic. It's making sure that you stay focused and resolved to get through it. It's the little voice inside your head that says, you can do this. You can get away from the tiger. So that's probably the most basic of its functions, which is probably going to be a surprise to people because of the brainwashing that we have about serotonin and happiness. It's meant to be in the context of stress. Okay, so the next thing is blood sugar levels, sleep issues, digestion, peristalsis, a whole range of things. A better way to put this perhaps is like this, where you have a baseline of autonomic functions. And this is quite helpful when you're dealing with people who have complex issues that don't seem to have a connection. When you look at the basics of their neurotransmitters and then you look at the symptoms of either not enough or symptoms of dysfunction, you can pretty well figure out what their neurotransmitter patterns are going to be from their symptoms. And I found this diagram very helpful for doing that as well. So you can see in the autonomic side of things, we've got peristalsis here. So the lack of serotonin is going to cause constipation. The difficulty regulating the heart rate because there's serotonin receptors in the pacemaker. Respiratory rate, temperature, that's probably the commonest one you see in children. They seem to be at odds with their ambient temperatures. They're the little ones running around in singlets and shorts in the middle of winter, and everyone's screaming, put some clothes on, or wanting to go for a swim in the pool in the middle of winter because they seem to be oblivious to ambient temperature. And then the next set of abstract emotional issues are cognitive inflexibility, lack of optimism, anxiety and obsessions. And then above that, you've got issues like eating issues. It's because serotonin is involved in appetite. And behavioral regulation issues where, especially in children, they learn from their surroundings about what is appropriate reactions to adverse events, say. So instead of going, oh yeah, my smart little brother being, a nuisance, they'll go and trash the room for 2 days. So early on they would have known that's not appropriate. You just wash it off and say, that's fine. I'll get mummy to help me clean it up. So turning around an adverse situation to something positive is serotonin's job. Little voice inside the head that says, oh, it'll be okay. Now, one thing that we have noticed since the advent of these drugs, and there's something like 15,000 cases per year in the US of this thing called the serotonin syndrome, with surprisingly little deaths considering the number of the people turning up with this problem. And this is to do with excess serotonin. And typically it is related to medications and perhaps a bit of misadventure. But what's interesting about this list is the autonomic effects, the hypertension, the tachycardia, the nausea, and the diarrhea. And that is probably the most surprising of the symptoms of serotonin excess. And it's to do, and they look awfully like high levels of adrenaline. And that goes way, way back to where serotonin may well have been mislabeled as adrenaline mimicking factor. So that's the end of part 1, and there'll be more in part 2, and we'll see you then.